Now, can I invite Dr. Neeraj Manchanda? He is going to deliver talk on achieving 20 by 20 with the PCR. Dr. Neeraj Manchanda again comes from New Delhi, from Healing Touch Eye Center, and he's a great anterior segment and posterior segment surgeon. Dr. Neeraj Manchanda, please. Meanwhile, if you have any questions, you can please pass them on to me so that we can have the discussion at the end after the talks.
So can I start?
Yeah, please.
Good morning, everybody. It's a wonderful morning. The weather is perfect outside. And thanks for Dr. Bhala for inviting me to this dais and speaking a few words about this problem, which is a very, very common problem, a posterior capsular rent, achieving 2020. So what are the risk factors for a PCT? So basically it is poor visualization. There could be a corneal opacity. Initially we can always, somehow when you are starting a surgery, you can make out that this kind of cataract is going to create trouble. So these are some of the points that you should not miss during the clinical exam. A posterior polar cataract, which is very important, with the latest machineries and gadgets available like the anterior, which is available at the Healing Touch Eye Center. We can now even see whether the posterior capsule, the polar cataract is penetrating the posterior capsule or whether the posterior capsule is still intact. So modern technology does help even more. It could be a post-traumatic cataract, a cataract with a small pupil, pupil not dilating. Make sure that you write on your file that this is a small pupil cataract. This is just an indication in the beginning so that when you are starting to operate, your team is ready with pupil expanders or whatever you want to do. Then weekend zonule pseudo exfoliation and any vitrectomized eye. You have to be very careful. I also do posterior segment retina surgeries. So we have to be more careful with the patients that are operated vitrectomy. Small capsular access during the surgical, extended capsular access when you are operating, uncontrolled hydrodissection can lead to this problem. And then there could be a surge in the machine could be faulty, or maybe you are not operating properly, running after small pieces and improper IOL insertion. These are certain predisposing factors. When you're operating, you should try to avoid these things, which I have written here. So what are the signs of catastrophe? That something has happened, maybe a rent or maybe the nucleus is going to drop. There is a sudden deepening of the chamber. You must stop there. Inability to rotate the nucleus, dipping of one pole of the nucleus, or there is an altered reflex in the periphery. So these are some of the things that you can make out that something is wrong is going to happen. What an anterior segment surgeon can do. A PCT or zonular dialysis can take place at any stage, mind me, any stage and any time of your career. It is not that I am operating for last now 25 years. Still, once in a while, something happens, and it is how you manage it that is more important rather than why it has happened or how it has happened. The management, the correct management is the answer. And don't panic, face it with a cool head. PCT does not always necessarily mean that there is a vitreous loss. It could be a small tear, and if you manage it well, you can do wonders. Everything is as normal as before. So how to avoid vitreous loss? Maintain the anterior chamber, use viscoelastic liberally, use of viscoat, dry aspiration, and in case of zonular dialysis, use endocapsular ring. So I'll show you a small video. So you can see here, this is a classical posterior polar cataract. We are doing the rhexis, a hydrodissection. This is a gentle, not dissection, only hydrodelineation in this case. You can see how I'm removing the nucleus, the epinucleus, and now you're going to see that sign here. See, this is where the capsule gives way. So after this happens, we are doing a dry aspiration, injected the viscoelastic. So I've cut short the video just to make it interesting. So you can see now we are trying to do a posterior rhexis so that I can implant a posterior capsule, a posterior lens in the back. So I am doing a posterior rhexis. I tried to complete the rhexis, but somehow it extended from there. But doesn't matter, you can still implant in lens. So I did this implant with a optic capture. So you can see did not go completely into the bag, but the optic is in the bag. You can see the capture lines, the optic is in the bag, and the haptics are outside. So this is how you can proceed. So no vitreous loss. So if there is a vitreous in anterior chamber, that case there was no vitreous. Phaco aspiration should be avoided. Immediately withdraw the phaco probe, but maintaining the anterior chamber, clean the vitreous around the nucleus. A dry vitrectomy or a visco-assisted vitrectomy is the thing that is to be done. But what is not to do is, do not withdraw as soon as you see something wrong, do not immediately come out of the chamber. That can lead to loss of pressure in the eye and the vitreous can come out. Let it never collapse. With the other hand, you can inject the viscoelastic. So conventional methods are to be condemned. If you have all phaco machine these days have an anterior vitrectomy option, always be ready with it, especially the cutter should be ready. When in case of panic, most of the surgeons I have noticed that they don't have a cutter ready with them. Machine is ready, vitrectomy is ready, but cutter is not available. Always keep a cutter with you, ready at hand. And automated vitrectomy is the choice of the present situation. What is the problem? The problem of automated vitrectomy is in our head. We have been doing a lot of courses in our hospital also, teaching people on model eyes about anterior vitrectomy. Don't be scared. It is a very simple procedure. Why I cannot do it? It is so easy that it is not difficult at all. These are the basic principles: cut before aspirating, no pulling, no hydration, balanced fluid egress, and direction of the cutter should be anteriorly. And section and anterior chamber should be vitreous free, and automated vitrectomy is the choice with a new cutter. Bimanual irrigation and cutting is preferred. Remove vitreous completely from AC and back and free the corneal and scleral wound. And again, free the pupil. That is the end point. Pupil should be freely mobile and constricting well at the end. So this is another video. This is a very old video. But again, these things don't happen so commonly, and most of the time we are unable to record. So you can see here around a grade 2 to 3 cataract. Pupil is small. We were aware that something could happen. But what happened in this case again was not expected. We had almost finished the surgery, so you're seeing the hydrodissection being done. The nuclear pieces are being emulsified and aspirated. So epinucleus is left, and now you will see what is going to happen. Just have the concentration on the center part of the capsule. Accidentally, this is here the capsule is gone. So this is, sometimes this can also happen. So this was luckily caught on the video. So these things can be avoided. So now we are doing a dry aspiration like I told you. And when the vitreous comes, this is dry, injecting the viscoelastic and doing a dry aspiration slowly. You have to be very calm, don't panic. That is the message. And whenever there is a slight vitreous coming out, you can use the anterior. See, this is the anterior vitrectomy cutter. Just to show, I have kept the cutter straight up. This is the direction the cutter should have. And then we can do a bimanual. We can go from one port, see bimanual. This is the irrigation and this is the cutter. So this is how the cutting should be done. Clear the free central area zone and remove the cortex. So what are more ticklish problems? So we initially discussed a PC rent without vitreous loss. Now we have discussed PC rent with little bit of vitreous, and now the most complicated part, PC rent with nucleus in the vitreous. Nucleus going in, the full nucleus going in, or pieces of the vitreous. So we don't have to run after. If the nucleus is going in, the best part is to let it go, let it drop. I am a retina surgeon also, so I know what to do. Even I don't go after the nucleus. I will do it maybe the next stage or same day if everything is available, my vitrectomy machine is ready, everything is okay, we can do at the same stage also. So are you a qualified vitreous surgeon? Go ahead. If not, then call a vitreoretinal surgeon. There is no need to panic. A lot of studies have been done which show if you don't operate the same day, it is not going to create hell. It is going to be okay. Calm down the patient, tell them the truth. The truth has to be told to the patient that there was a problem, this has happened, and we'll take care of it. So that is very important. What you should not do is try to remove the pieces which have gone into the vitreous. Don't run after them, and never put a wire vectus in the vitreous. That can cause a lot of problem. So you can do it either on the same sitting if you have a qualified surgeon and the things are ready, or defer next few days, calm down the patient, do his anti-inflammatory treatment, and then when the pressures are okay, you can do the things. So your present imperfect handling of vitreous may make your future tense. This is a very important message. And what you can do is anterior vitrectomy, cortical cleaning, and PCIOL, if you are confident, you can put, or leave it for the vitreoretinal surgeon to do it if there are pieces in the vitreous. So this is another very old video, just to show you my last video, and half a minute to go. So you can see here the vitreous, already there is a rent, because this is a very old recording. You can see we are trying to do the dry aspiration with the help of cutter also, and removing the cortex. So what you can see is, you can see a big nuclear piece behind, and now see where it is going. It is going down, so let it go down. Don't run after it, and then you suture. This is my message. If it is going down, suture it and leave it for the vitreoretinal surgeon to do. So this is the message. Do not fish for the nucleus. Thorough anterior vitrectomy, remove cortex with dry aspiration, IOL insertion only if you are confident, and refer to the vitreoretinal surgeon. And last but not the least, tell the patient the truth. That is most important. In the era of medico-legal cases, it is very important to disclose the truth. Anything can happen. The best of the pilots or best of the drivers can have an accident. So that is my message. Thank you very much. And thank you very much, sir, for inviting me again. That's it.